Now it's my pleasure to introduce the second speaker in the session, Dr. André Ilbawi. He's the Technical Officer, Cancer Control Department of Noncommunicable Diseases Division of Universal Health Coverage, WHO Geneva. André was trained as a cancer surgeon at University of Washington and MD Anderson. And also he's heavily involved in clinical and research efforts, focusing in cancer care in low resource settings, health system departments, and also strengthening cost-effective surgical services. Dr. André is going to present global health crisis, challenges, and opportunity. Dr. André.
Thank you. Good afternoon, colleagues and friends. It is a true pleasure for us to be reconnected with experts in the region and beyond, many of you who we have a very privileged relationship with. So thank you and welcome to all. May I also begin by thanking the organizers, the Gulf Center, Dr. Ali, for the invitation to speak at this prestigious conference. To the moderators, thank you for this important session, and the co-panelists for their important perspectives. As we heard already, we should also pause to give thanks to the providers on the front line. Those of you that have put your own personal health and your families at risk for the sake of responding to this pandemic. It is our privilege as WHO to have this platform and to reflect with you how we can respond to this global crisis. I have no conflicts of interest to disclose. I'm an employee of the World Health Organization. This is the key message here. The pandemic has laid bare how the world has failed to meet the needs of the majority of people living with NCDs around the world. It is a crisis. It is a crisis of cancer. It is a crisis of public health. And this pandemic, while we say this can be a once-in-a-lifetime event, we must be prepared for more. Because cancer patients have suffered, and they're suffering now in the context of COVID. Here's why. We know that the cancer burden is increasing around the world. We know that governments have made a commitment to respond, but often those responses are inadequate and insufficient. And when they do exist, unfortunately, the response at the public health level and at the clinical level has failed to meet best practices and international standards. The consequence, patients are suffering, inequalities are worsening, and we will fail to achieve the Sustainable Development Goals commitments that all governments have made. So we sit here at a crossroad between the pandemic and the existing NCD epidemic that is only getting worse. What is it that we can do to respond? This is how we'll structure the next 20 minutes. First, to understand the context, then to evaluate the current global response, and finally to reflect on what is WHO doing to support governments around the world. The cancer burden. Here you can see an example of the cancer burden in the region, Bahrain. Between 1999 and 2012, they saw a near doubling in the cancer burden. Now let's just put this in another context because the increase may only be 200 patients, but this is how we can better understand it. To say that we now have to double the infrastructure, double the number of hospital beds, double the number of providers, double the resources that are allocated to cancer to respond. And when we consider risk factor prevalence in the region and beyond, this is only going to get worse. When we project towards 2040, we may see another doubling, particularly in low and middle income countries. Cancer already is a leading cause of death. It is responsible for 1 in 6 deaths globally. It will soon become the leading cause of premature deaths in the majority of countries around the world. So what is it that we can do to respond? As mentioned, the starting point is always a coherent national strategy or a cancer plan. When we look in the region, we can see that there has been significant progress in even a 4-year interval between 2013 and 2017. The number of countries that developed a cancer plan went from 48% in the Eastern Mediterranean region now to 71%. There has been progress in specific domains like cancer prevention and cancer early detection, but unfortunately that there are many still left behind. We see deficits in coherent planning for treatment, for service delivery, considering rural populations and service structure, and of course, the need to build a health workforce that is competent and available. And more importantly, we see that often plans are just strategic documents without any teeth, without any implementable actions. So unfortunately, only 7% of plans have a mechanism to see how and if they are being successfully implemented. Only 10% have a budget allocated to it. So while we are developing plans, this response to date has been inadequate. Let's also think about strategic investments. If there's anything we've learned from this pandemic, it is that health is amongst the highest priorities. For governments, we see investments in infrastructure, important, education, important. But do we think about health as a priority in the broader budgetary planning for governments? And unfortunately, when we look at proportional allocation to health, it remains low. It remains low in the region and it remains low globally. And for cancer in many settings, it is also proportionally low, leaving patients with the burden of paying for cancer care out of pocket. And this for us really is a moral call to action that this pandemic again has highlighted. If we look at financial catastrophe rates, that is the number of people who are selling their homes, selling their possessions because of a cancer diagnosis, these rates are incredibly high. They can be as high as 70 or 80% in some regions. And this is not just a matter of losing one's home. We see the impact on the health of the family suffers if even one person gets cancer in that specific family. We also know that standards have been insufficient or incoherent. As an example, when we look at the WHO list of essential medicines, we see many countries gravitating towards high-cost technologies, but not investing in what we consider the basic or the essential treatment packages. And then finally, national guidelines are emerging, but many of these national guidelines do not adhere to best practice. As an example, screening women who are less than the age of 40, or screening women for breast cancer when there is no opportunity to diagnose and treat for that population. These are incoherent policies that introduce inefficiencies into the system and exacerbate an existing crisis. And then finally, to look at the trends in the region. So we all know that our target is to achieve a 1/3 reduction in premature mortality from NCDs, including cancer. The Eastern Mediterranean region is behind this already. And when we ask why, is this a matter of which cancers are driving this failure? In fact, it's across the board. We see that the Eastern Mediterranean region is performing worse in the world in almost all the major cancers. In breast, lung, colorectal, prostate. In fact, so many so that you can see from the graph here that trends in premature mortality are stagnant or in some situations increasing. So what is it that we need to do in the face of these two pandemics? Well, to begin, let's understand this context in the region. So this is data from Concord, which looks at survival probabilities from registries around the world. We can see that registries in Asia have huge variability in breast cancer survival, ranging from 30 or so percent to 90 or greater percent. So what explains this variation and how can we bridge it? This fundamentally is the public health question that we ask. So if we look at that difference, the 30 to 90% difference in breast cancer survival, is it high cost technologies? Is it coverage? Is it early diagnosis or screening? Well, we can in fact break it down. One of the largest contributors is in fact late stage disease that is still all too common in the Gulf and in the region. Another factor, treatment complexity. So yes, improving access to high impact and high cost technologies can make a difference, but let us understand the context. That is a huge investment in those advanced technologies with a lower overall benefit in terms of survival gain than what we see with downstaging. Quality. Let us remember that quality remains a core pillar of the cancer response. Qualified workforce, quality and service delivery, and the national standards to surround it. And then finally, coverage. We cannot ignore the fact that one of the reasons we fail to make progress in many countries in the region is because simply everyone in that country or in that setting doesn't have access to care. And when we talk about earlier diagnosis, it is important to distinguish between what we call early diagnosis of symptomatic people versus screening. Even in a country like the UK, only about 5% of their cancer diagnoses come through cancer screening programs. So we have to set up the infrastructure to deliver on early diagnosis pathways. But this is also the key message. For us to deliver on the promise of universal health coverage, we must invest more in service coverage. And how about the COVID pandemic? It is setting us back in every regard. If we use these same parameters to understand why are we seeing now worse outcomes during the pandemic, it's because of a lack of ability to access care, because of quarantine, or because of fears of contracting COVID. Treatment not available, medicines that are no longer available because of stockout and shortages, treatment standards that are being compromised because of a variety of inputs, such as medicines not being available or hospital beds running out. And of course, critically, delays that we're seeing in almost every country around the world. And this is compounded by the realization that we know for some cancer patients, they are at significantly higher risk for COVID-related death and complications. At WHO, we've developed a model now to help governments understand how to set these priorities, how to understand how the impact of COVID is translating into cancer services, and what the ultimate output will be for cancer lives and cancer deaths. Here's an example of some of the data we gathered. We've done 2 systematic reviews looking at these different parameters to try to understand, again, how cancer and COVID relate. As mentioned, we see an interplay between certain cancer types and an increased risk of COVID-related complications. We know that in some settings, up to 90% of patients or more are experiencing delays in diagnosis, and this results in more advanced disease. We see patients that are unable to complete multimodality therapy, as high as 65% in some settings, patients that are interrupting or abandoning therapy because of the pandemic itself, and those that we also anticipate will be at greater risk of COVID in the next decades ahead because of uptake in unhealthy behaviors. So this impact is huge. And at WHO, we're ready to have discussions with governments to understand how to set priorities and define a response in that setting and define a response globally. When we look at the question of are we ready, were we ready at the time? We also at WHO did an analysis of emergency response plans or COVID response plans and found, unfortunately, the vast majority of governments did not include cancer or NCDs in those plans. So while we were told and we reviewed that 38% of countries did report NCDs in their essential health services, only 3% had a budget line attributed to it. Only 10% gave any concrete guidance as to what this would mean as it pertains to maintaining essential services. As we know, this is the greatest challenge of our time, but we must be ready for this challenge to continue and for challenges ahead that will be like this. And there is an important message here of solidarity and understanding how health really is fundamental to the human experience. So what is it that we can do? What are some of the recommendations that WHO has promoted? You can see here one of the first ones. What in cancer is essential? We all know that cancer is a time-sensitive disease, but there are some that are absolutely urgent and there are some that can wait. How can we start understanding how to make this response at the country level? How can we also designate what hospital beds must be maintained for cancer patients? How we can maintain also a COVID-free zone as we've seen in some countries. Linked to this concept of essential services is also addressing the communication gap. We know that soon after the pandemic started, the impact on cancer and the fears in the community were huge. In fact, if you did a Google search looking at COVID and cancer, cancer was one of the most common diseases that people would Google search for, trying to understand what does this mean for myself, for my family, and my ability to seek care. But the challenge has been we got behind in the narrative. We created a message that yes, cancer services are essential, but we didn't give any concept as to how we can manage this increased need to care for cancer patients in lieu of pandemic. So as a scientific community, we do have a responsibility to come together and define what are those essential services and ensure that patients have access to those services. We did another systematic review looking at mitigation strategies. There are only 9 published studies that presented evidence-based results on mitigation strategies, 9. So we must develop the implementation research, the outcomes-related research that can help us understand what health services should be prioritized and how do we maintain them. This pandemic has also shown that our global health architecture is fragile. We see NGOs that have been relied on to provide services or to coordinate services see their funding almost evaporate overnight. And what does that mean for a cancer patient when those civil society organizations are no longer there? We see pharmaceutical companies also shifting their priorities. And while we don't know the long-term consequences, we should be ready for them, and we should be ready with further contingencies in the future. And of course, the greatest concern is that those that were already having a difficult time accessing services are even worse now in the pandemic, more vulnerable, more disadvantaged. So what is it that we at WHO are doing? As a starting point, earlier this year, we also released the Global Report on Cancer with thanks to Dr. Samar Al-Mahood, who is also part of this esteemed group and will be presenting later today. She was on the editorial committee as we developed some recommendations for governments to set priorities, to invest wisely, and to provide care for all. So now we have a strategic approach. We have a way to tell governments, invest this in cancer, you can save up to 1 million lives per year already by 2027 and more than 1 million lives thereafter. Almost 10 million lives by 2030. Just think about that in lieu of the pandemic. We're not going to achieve it unless we change our strategic approach now. And when we look at the investments that are required, they are not huge. We're talking about per capita expenditure on the order of almost $10 for an upper middle income country. So how do we set these priorities? What do we need to invest in? It's important to understand also one of the most strategic investments is people. So we looked at it, what are the driving costs for us? What is required for us to achieve this target? And it is a trained workforce. Of course, we have to think about infrastructure, medicines, technologies, etc. But also we must remember a trained workforce. Because if we're going to scale up services, if we're going to be ready to respond in the need of surge situations as we've seen in this pandemic, we need to train more people and be ready to do so. And the justification is very clear. The return on investment is high. It is justifiable for us now to make these investments. And we thank leadership, such as what we've seen in the Islamic Development Bank, that has come forward and said, yes, we understand that in fact, cancer is a strategic investment that we believe in. And we look forward to working with development partners like the Islamic Development Bank to build that narrative at the country level. These principles are also reflected in the Building Back Better structure that WHO has highlighted. And here's the 11-point action plan that I'll just show for reference. So how can we get engaged? How can we ask you to participate with us? Well, this mandate comes because governments told WHO, you must do more, and we believe that we need to do more to respond to this cancer burden, and of course now to the interface with the pandemic. We can build back better, but it will require all of us to do it. At WHO, we have a variety of products, as I've mentioned, and initiatives that can help governments drive towards that improvement in cancer care in the next decade. But critically, we must recognize that it includes participation of all of us. All of you on the call and beyond, how in fact can we build the cancer agenda together and implement it at the country level? Just a brief mention of some WHO initiatives that are supporting now implementation at the country level. We have an initiative in childhood cancer with a global target to improve survival. We have a strategy to eliminate cervical cancer, which I hope you are aware of. It was recently launched on the peripheries of the World Health Assembly now 2 weeks ago. This is really a unique opportunity for our community to stand behind this moment in time and say we were part of the elimination of a cancer. And in the next few months, we'll be launching an initiative in global breast cancer control. We welcome you to be part of all of this with us. We welcome you to respond to these two pandemics and do so successfully. First and foremost, as we close now, the impact of the pandemic on cancer is getting worse with time, and it will have major consequences on us as individuals, our communities, and the broader global health architecture in the upcoming decade. But if we take a step back, investments in health must be seen as a priority. They are justifiable. The investment case is strong, so we must act now. But this is founded on the recognition that investing in health is a political priority, and it is our responsibility as a community investing in health to drive that at the political level. And if we don't, what happens? We know that while the rising tide of public health can lift all boats, at the same time, raising inequalities from NCDs will sink all boats, will introduce a fractured community, fractured services, and inferior outcomes for everyone in the end. So we must do so with solidarity.
1 minute to conclude.
Message. How can we achieve progress, recognizing that these types of communities like what we see here today is what will achieve our success, coming together as a community against cancer and dealing with this pandemic that is impacting